All right. Next, really my pleasure to welcome Dr. Kylie Culp. She is a generalist in the OBGYN department at Denver Health. She comes from the Windy City, where she recently completed her residency at the University of Chicago. During residency, she served as the administrative chief resident, and her research focused on improving medical education for future generations. She's dedicated to improving quality of patient care through policy review and changes, and currently serves as the lead physician for the ambulatory OBGYN clinic. Prior to residency, Kylie completed her undergraduate and medical education at the University of Michigan, and she made sure to write "Go Blue." I don't know what it is about people from Michigan. It's just like "Go Blue." They're just so passionate about being Michigan folks. All right. Outside of work, she can be found playing with her pandemic puppy or helping her husband transform their new house in Denver into a home. So welcome to Denver and welcome to the Chosen Forum. We really appreciate your being here, Kylie.
Okay. Hi, everyone. Thanks for that wonderful introduction. As you mentioned, my name is Kylie Culp. I'm one of the OBGYNs from Denver Health. It's really special to be in this room. And where this kind of presentation came from is that the CPCQ, oh my goodness, CPCQC put together a recent forum where they actually pulled together the OBGYNs and the pediatricians at Denver Health. And even though we're only one floor apart from each other, as you all know in this room, it's so incredibly hard to actually get us together in the same room and to actually be able to talk and listen to each other and know what we're all doing. I certainly learned a lot about what they're doing, and hopefully they learned a little bit about what we're doing. But for those who don't know, which I'm sure most of you do, the CPCQC has the OB side of Chosen called Moms Plus. And we started this almost 2.5 years ago at Denver Health. So this is just giving a little kind of introduction of what we've been doing. So some objectives. Number one, identifying leading causes of maternal pregnancy-related and pregnancy-associated mortality in the U.S. and Colorado. This is to cut to the chase. Drug-related deaths are our number one cause now, and they're also 100% preventable. And then the rest of the objectives are really just going through what we did at Denver Health and kind of what we've been trying to change. And I will give the caveat that we certainly are not at a perfect place yet. I feel like most days I go home and was like, I wish that would have been different. I really messed that up. But I think every single day we're moving closer and closer to a better place for our patients, or at least that's what I hope. This is actually from a presentation that was given at the DIAD conference a few months ago, held in this exact same room. But I thought it was a really good way to start a presentation on substance use. And it says that we can all come together with the assumption that exactly what this quote says: addiction is a chronic condition, treatment works, and recovery happens all the time. This was from Dr. Turplin, who is at the Friends Research Institute at UCSF and a substance use warm line clinician. And I try to kind of every single time that I'm working in the space, always try to bring this to the forefront of my mind. So the Center for Disease Control and Prevention recently released sobering data demonstrating that the maternal mortality rate has yet again risen in the United States. We've probably all heard the NPR podcast. We've read the New York Times articles. We've heard all the news that the United States just frankly sucks when it comes to maternal mortality. And we're not, despite all of our efforts, we're not getting better. But nationally, the leading cause of maternal mortality includes drug-related deaths and suicide. The majority of these occur during the postpartum period, which, as an OBGYN, I'll be the first to say, we also really suck at taking care of people in that postpartum period. We are seeing them almost every single week, it feels like, until that baby's born, and then we say, okay, adios, we'll see you in 6 weeks. Hope you can figure it out. Talking to my pediatric friends and colleagues, honestly, you guys are doing a lot of the postpartum care, and we need to be taking some of that ownership back onto us, especially knowing that this maternal mortality is happening. Between 2010 and 2019, drug-related maternal deaths have risen over 190%. While most patients will achieve abstinence or recovery during pregnancy, up to 80% will relapse to at least one substance in the year following delivery. In addition, the postpartum period is the highest risk for maternal suicide and unintentional drug overdoses, further underscoring that need for additional support. So this is actually Colorado specific data. And you can see here on the left-hand side of this screen, pregnancy associated versus pregnancy related. For pregnancy associated deaths, this is really any deaths due to any cause versus pregnancy related. This is more things like postpartum hemorrhage, preeclampsia. So we're doing slightly better on things that are pregnancy related, but we're not doing better on pregnancy associated. And that, again, that's really driving that trend upwards in maternal mortality. And most importantly, though, is on the right-hand side of the screen. The Colorado Maternal Mortality Review Committee has concluded that 100% of unintentional overdoses and nearly 90% of all the other deaths are preventable. So there's no excuses. We all can do better to make sure that our pregnant and birthing parents are living and achieving their life goals and seeing their babies grow up. So again, just really trying to drive home the point here that studies have demonstrated over 1/3 of suicides in pregnancy in the postpartum period have substance use as the precipitating factor. And as you can see, suicide and unintentional drug overdoses are our two top causes. So pulling back a little bit, what does Denver Health look like? So we have over 4,200 births per year. I started at Denver Health just 3 years ago now, and over that course of 3 years, that has increased by over 1,000. Just to give an idea of kind of the other things happening at Denver Health at the same time is that we've had this rapid increase in our volume. We have a very diverse patient population, so close to 70% identify as Hispanic, 41% speak a non-English language, and 85% are publicly insured. Our prenatal care is also pretty fragmented, which I think is a really positive benefit of Denver Health is that patients can have so many different areas that they can access prenatal care, but it's certainly hard when you're trying to roll out a whole new initiative of how are we going to take care of all of these patients with substance use. But prenatal care is provided at over 15 different clinics. It's staffed by family medicine, OBGYN, midwives, and other APPs. In 2022, when we did our initial kind of needs assessment of looking, okay, what do we need to do at Denver Health? Close to 12% of our pregnant patients had a marker of substance use. And you can see the breakdowns between opioids, alcohol, and marijuana there, marijuana being the highest. So even though the incorporation of substance use and substance use care into routine prenatal care has been identified as best practice by ACOG, the Alliance for Innovation on Maternal Health, and SAMHSA, implementation into clinical practice has been limited. In 2022, Denver Health was selected as a pilot site for a statewide initiative called Moms Plus, Maternal Overdose Matters. And this initiative intended to provide universal screening, dismantle barriers to treatment, and improve availability and utilization of healthcare and community resources. When we started this, Kaylin Klee, who you probably all know and love as much as we absolutely love her, she was at Denver Health about 1 day a week, and she was actually seeing all of our patients with substance use, which was a huge undertaking for her. And truthfully, in my mind, not fair that she was seeing all these patients when we take care of so many different disorders in pregnancy that we could learn and take some of that burden off of her. So as I mentioned, we are still very much in the process of figuring this out, and truly every single day, like I said, I go home and it's like, oh, well, that didn't go as I expected, but that's okay. We will try something different and hopefully we'll continue again, kind of every single day. Even if it's a small step forward, it's still a positive step forward. This is very, very hard to see, and I don't expect you to be able to read this. But when Stefka and I first sat down together and we're like, okay, how in the world are we going to start putting together all of these different pieces of this really big implementation? It was very overwhelming, and we had a lot of meetings where we sat there, and I felt like we weren't kind of making a lot of that forward progress just because I felt like it was just such a big undertaking. How are we going to fit 15 clinics, family medicine, OB, midwives into this model and somehow make it work for our patients? So this was one way that I found was actually really helpful. My husband is an architect and he actually told me about it. I had never heard about it before, but it's called Miro Board and it almost acts like a Google Drive or a Google document in the sense that you guys can anyone, any number of people can log into it at the same time and make changes. So we really tried to break it down into more feasible ways that we could approach this so it didn't seem like such an overwhelming undertaking. So you can't read it up there, but essentially it's divided into prenatal care, peripartum, so what does their delivery on admission look like, and then postpartum care. And we constantly are going back to this, even now that we're almost 3 years into this initiative. One, to see, tell us, okay, you guys are actually doing something, and you can see these like little red check marks that, yes, we got something done. Gives that positive reinforcement. But two, going back and kind of revising what we have done and saying, okay, that didn't work, let's try something else. And then as a reminder of what we still need to do. As I'm sure on the pediatric side as well, there are so many teams involved. And I honestly, when I was going through and making this presentation, I realized we didn't even have our pediatric colleagues on here, which I will add for future presentations. But there's so many different pieces that in teams and people that this touches. So every single time you make a change, it has that kind of like ripple effect across the entire hospital system. We're lucky at Denver Health in a way because we are pretty, even though I said that our clinics are spread out, we're still, it feels like a small family and a small like home that we can make changes actually pretty quickly. For example, our urine toxicology policy, we were able to push that through in like 2 weeks, which I was very proud of, but um it's there's still like just so many teams involved that it certainly is a challenge. And then this is a breakdown of kind of how, and really this is based off of the mom model, but how we approach this and how did we say, okay, how are we actually going to integrate substance use, opioid use care into routine prenatal practice? So starting with prevention, doing universal screening, multimodal non-opioid analgesia, trying to figure out how are we going to change the stigma and bias that exist within our staff, harm reduction, standardization of clinical practices, and then increase access to treatment. So prevention. This starts off with universal screening. We do this, and this is what we decided works best for Denver Health. Ideally, I would like to eventually expand this to the postpartum period. But for right now, what we're doing is at the very first prenatal care visit, and then we have a second touch point on the admission to labor and delivery. As we've heard in a lot of these presentations and in a lot of these conferences, is there's so much stigma and bias associated with substance use and a lot around DHS and CPS reporting that people don't want to disclose to us. So either they don't disclose or they just don't show up for prenatal care until they're having a baby. And we really want to try to have those multiple touch points. So hopefully we can build trust with these patients and hope that they can trust us that we are acting hopefully in their best behalf. This 5P screening is performed by our nurses, both on the outpatient side and labor and delivery. And then we've built a lot of changes within our Epic system to make sure that these screenings happen and people can't just skip over them. So there's a lot of hard stops. As of next week, we're actually going to have a new like Epic rule that takes the screening and puts it into all of our notes if it's positive. And that includes on the pediatric notes as well, so that there's like it's truly in everyone's face and you can't just ignore it and skip over it. Another part of it is just that we want every single person to be screened regardless of their race, ethnicity, religion, whatever. So if everyone has to do it, then great, universal. allow us for data collection. And then we have some other rules built in that if a patient screens positive on 5P, they automatically get handouts added to their My Chart so that they can start doing learning on their own. And I realized, and I meant to change this and I forgot. This question number 5, this is the one that we actually care the most about. And this question isn't quite worded the way we have it worded. We have it worded, since you found out you're pregnant, do you feel like you have a problem with alcohol or other drug use? Not just related to alcohol or other drugs. We're starting to get more and more data. This is definitely an area that I feel like we have some improvement that we can do, but we're getting closer and we have a few meetings coming up in the next few weeks about using smart firms and smart data elements that I really hope will help to further enhance our data. But as you can see, specifically for substance use disorder and depression screening, we have dramatically improved our rates from around 60 to 70% to almost 100% of all patients. And we don't have quite enough data to look at specifically race and ethnicity yet, although we are collecting that data, but it seems like we are eliminating any biases or trending towards eliminating any biases based off of race and ethnicity. On the same prevention topic, this is for all patients, regardless if they have a substance use disorder or an opioid use disorder, but we have a multimodal pain medication regimen. So all patients on the OB service have this instruction at the top of the screen within the discharge navigator. And this is a publication that's still pending at Denver Health, but so you guys are getting insider knowledge. But for OB patients, regardless if they had a vaginal delivery or a C-section, we looked at non-tailored versus tailored opioid discharge prescriptions, and we had a dramatic decrease once we started using these rules that are on the top of the screen. So the mean MME that the patient was discharged home with went from 50 down to 18, and the number of people discharged home without an opioid prescription went from around 40% to over 60%. We know that from a lot of like big population data that a lot of patients start using substances related to pregnancy related events. So if we can take even a small part in hoping to potentially prevent someone from developing a substance use disorder, we also wanted to make sure we were addressing that side of things. They did specifically also look at, in the study, I didn't include it on the slides, but whether or not the patients had higher pain scores, if they were more likely to return to the OBED or call for additional pain medications, and there was no differences between the patients in the tailored versus non-tailored groups. Oh, sorry, the formatting got a little bit messed up here. But we have also made it mandatory to do stigma and bias training by the CPCQC for all of our staff. This includes patient access specialists, so those very first people that the patients see when they walk into our clinics or into the hospitals, medical assistants, nurses, and providers, including attendings, residents, APPs, etc. This was some of the data that we got from the CPCQC. And you can see just the dramatic improvements in the before and afters of knowing how prevalent substance use was, how much it contributes to maternal mortality. And I didn't include it on the slide, but honestly, I think it's probably a little bit more important. We saw similar changes for questions about, I have thought about the circumstances of the patient's life story when they have a substance use disorder while pregnant. I felt empathy for pregnant or postpartum patients with substance use disorder, and I view addiction as a preventable and treatable disease that a patient is facing. And I think as we continue to make these small changes, it just overall changes the culture of the entire hospital to hopefully make it a more accepting place, a place that a patient wants to come, a place that a patient wants to disclose their substance use to get help and continue to receive care. For harm reduction, we've now have been successful in getting naloxone or Narcan to be able to distribute in both the inpatient and outpatient settings. So in the outpatient setting, we actually have this as a clinic administered med. But we've worked it out with the pharmacy that we can just give that medication to the patient directly and they can take it home. And for on the inpatient side, we actually give naloxone to all patients with new opioid prescriptions or a history of substance use or opioid use disorder. And you can see here on the bottom part of the slide, this line right here is about 200% of the proportion of at-risk visits receiving naloxone. So if I approximately divide that in half, I'd say we're pretty close to reaching 100% of our patients of making sure that they have naloxone with them. And we certainly, if they already have it, we say, great, here's another one. I'm constantly telling the residents, like, hand it out like candy. Everyone can have multiple at home. They can give it to their friends, hand it out for trick or treating. Some parents might not like that, but you know. And then another big part of this is the standardization of clinical practice. So as I mentioned, we are now spread out over 15 sites at Denver Health. And it was really important to us to make sure that we had an OB, we call it PAIR, same here at the University of Colorado, so Perinatal Addiction and Recovery, that we had someone represented at each of these clinic sites so that we could try to remove all barriers that potentially existed for the patients so that they could get into those clinics. Also, if those patients disclose substance use at that like initial OB visit, we wanted to be able to schedule them an appointment as quickly as possible to ensure that we could try to keep them within care. Once a patient gets scheduled with OB pair, then the OB pair providers have a variety of different things that they have to do. Number one, determining if a use disorder is actually present. Initiating a checklist for substance use and opioid use disorder. And this checklist is here on the side, which includes quite a lot of things. I think people, especially on the OB side, get a little bit overwhelmed when I see this. And I remind them that we have a checklist for pregnancy that's very, very long as well. We don't have to do all of this in one visit. It's supposed to be spread out across the entire pregnancy. Screening for comorbidities. We know depression, anxiety, and other mental health disorders correlate with substance use and overlap with it. So making sure that we're not just touching that substance use part of it, but really touching all potential parts that may make getting care for this patient harder. Making referrals if patients are interested, assessing interest in MOUD, and again, ensuring the patient has naloxone. So this is something that I worked closely with Lauren Bruns on, and I appreciate all of her help. And we're actually in the process of kind of redoing this as well to see how we can collaborate better with the pediatric side of things. But one of the things that we are really trying hard to do is develop the plan of safe care and start it in the antenatal period. We have the luxury, and it's one of the reasons why I became an OBGYN is that it's such a unique part of a person's life that they are accessing healthcare ideally at regular intervals, and you really, I feel like, have that ability to form that connection with them. But again, it's just that constant touch points with the healthcare system. So if we're having all of these touch points with them, why are we waiting until that baby is born to start this plan of safe care? And someone typically doing the plan of safe care, at least at Denver Health, that has known that mom or birthing parent for maybe a couple of hours, when we could start this on the OB side of things, and when we really, really know these patients. One of the other unique things about how we set up OB pair at Denver Health is that we actually ironically, pair the OB pair visits with an OB provider plus a substance treatment counselor. When we started developing all of this, we realized the rest of the family medicine clinics across Denver Health had a substance treatment counselor built into their clinics, and that was not accessible to any OB patient. But they have such an incredible amount of knowledge of things that I absolutely don't know about, all the different treatment levels and what services are available, what resources are available. So it's been really nice to have kind of this multidisciplinary approach of how we're treating these patients and that they're able to get counseling, they're able to get their OB care all within that one setting. So what we're working towards is that the substance treatment counselor is the one that is actually helping to create this plan of safe care. Again, another work in progress that we still have a lot of work to do on, but hopeful that we're going to get there. And then, so if any of you guys have ever worked at Denver Health, you will know that the policy stat, which is just a website filled a lot of guidelines, but it truly is our Bible within the OB department. We like live and breathe by that. So that was one of our first places that we started, was just starting to churn out policies of where could people go could people sorry, where could people go to that all the information was in the exact place that they needed to be in. They didn't have to look in a million different files. It's easily accessible and everyone knows how to access it. So we have a long one that's just labeled substance use disorder and pregnancy that goes through medications, counseling, a whole variety of different things. What medications you can prescribe someone for withdrawal, what else should you be thinking about? Plans of safe cares, things such as that. Other policies that we've enacted are changes in toxicology testing for pregnancy in the postpartum period, toxicology testing for newborns in the nursery, and then breastfeeding guidelines for substance exposed newborns. And on the right-hand side, you can see that these are our percent of delivering patients with drug panel screens and then percent of newborns. And continuously over the years, they have continued to further decrease, which we are really proud of, knowing that there's a lot of limitations around toxicology testing. I've touched on this a little bit, but just that idea of increased access to treatment. So when a patient comes in for their initial OB visit, they get that 5P screening. Let's say they screen positive. We, and I think this is probably a little bit controversial, but it's how we're doing it right now, is that we essentially kind of require the patient to have a universal referral to treatment for OB care. But it's regardless of their desire for treatment. So even if they say, look, I don't want to stop using, I don't want that, I don't want anything related to that, we say, great, that's fine. We are still going to have you see an OB pair provider, and you're just going to receive OB care from them. They're not going to push you to do treatment if you don't want to. You can, it's definitely shared decision making with that patient. But we do think it's important that if they screen positive, that they are still getting their OB care by an OB pair provider, just because that OB provider has a little bit of additional training and knowledge. And then this part is not mandatory, but as I mentioned, the paired visits with the substance treatment counselor, that's only if the patient would like to meet with a substance treatment counselor, but it's definitely highly encouraged. For patients who have like essentially kind of fall into the category of OB pair is anyone who has obviously active substance use, but we also include anyone who has substance use within the past 10 years, knowing that pregnancy and the postpartum period can be a really challenging time. And we, again, just want to, as much as possible, drive up that support amongst people. And then here, this is where, again, we've tried to create as many like workflows and ways of getting patients into the care as much as possible. So this involves working on both the outpatient side and the inpatient side so that all the providers know how these patients can get into OB care, and making sure that we're trying to remove any barriers that might be possible. And I was going to end the presentation today with a little video from Hard Beauty, but I saw on the agenda that they're speaking, and they will be able to speak a lot better than I will be able to speak about what they do. And they have such an amazing story. And I truly think is one of the most helpful parts of anything that we're doing on the OB pair side is just our linkage with peer coaches through Operation Care and Hard Beauty. And I'm really, really proud of this. At Denver Health, we have actually over 70% of our patients since we started recording data about a year ago that have been linked with a peer recovery coach. What the data we don't have, and something that I would love to continue working towards, is how many of those other 30% were offered and said that they didn't want that or didn't need that right now, versus are we just missing an opportunity there? One of the other things that we are doing, trying to do during these OB pair visits is an emphasis on anticipatory guidance. So we talked to them about DHS or CPS reporting guidelines. This is something that I will be 100% honest on. We are working really hard at Denver Health, and we're coming up against a lot of brick walls about people having different opinions about who should be reported, who shouldn't be reported. That we escalated it up to the point where we're now doing a rapid improvement event through our Lean Academy of trying to come together with, again, getting all the people into the same room, knowing that everyone's coming at this with a different perspective, but we all have the same goal of that we want to keep this birthing parent safe and we want to keep this baby safe. And how can we achieve that goal? Well, being patient-centered. So more to come on that. I think we've made a little bit of progress, but we still have a lot of progress to continue to improve on. We talk to patients about what our urine toxicology guidelines are, and we try to give them information so that they can empower themselves about the limitations of urine toxicology. And this is another thing that I'm super excited about is the NOWS emission. So if you have a bunch of, the family medicine providers are certainly better at it, but if you have a bunch of OBGYNs talking about what a NOWS emission looks like, we aren't going to do a very good job. I think we all can say eat, sleep, and console pretty well, but we don't know a lot of other information beyond that. So we now have a new option as a few months ago of one of our pediatric providers at Eastside can actually do a telehealth appointment with the pregnant person so that they can discuss what that hospital stay may look like and how they can best help their babies. And when we initially started discussing this, there's certainly some, just like, I feel like there were some like thoughts, okay, how are we going to schedule a adult into a pediatric clinic? How are we going to bill for this? Those kind of like barriers that came up. But then we took a step back and we said, okay, for example, I read OB ultrasounds, and if we have a patient with a club foot, we're getting them in to see the pediatricians before that baby's born. If we have a patient with a cleft lip, again, we're getting them in to see the pediatricians before that patient's born. So why is this something that like all of a sudden we can't do this? So we had to work through some barriers, but eventually we were able to get it set up and kind of using those other examples of we do antepartum consults all the time. Why can't we just use that model? And that was what eventually allowed us to overcome that barrier. In the patients that I had one patient recently who did the telehealth appointment. And again, it's just that empowerment as much as we can to empower them to learn themselves, to advocate for themselves. And of course, we'll try to advocate as best as possible, but they are always going to be their best advocate. This is a video of Raquel, but I'm going to let her talk instead of letting the video talk. And then I stole this from Hard Beauty's website, which I thought was such a great Indian side of don't give up. You are not alone. You matter. That is the whole kind of purpose of OB Pair is really trying to create as much of a support system, whether or not that's doctors, nurses, social workers, peer coaches, as much as a support system and a pillow that we can catch these patients, even if they don't meet their goals in pregnancy or in the postpartum period, that we can continue moving them forward the same way that I kind of talk about the OB Pair program, that if we can continue to make slow, steady steps forward, it doesn't have to be these huge steps. It can be slow, and that's okay. And I think that is all I have.
I'm always so impressed by what happens at Denver Health, which serves our underserved population. It is our safety net hospital, probably the least resourced healthcare system in our state, and yet is doing this sort of innovative work. And so this is the passion of the providers and the larger team at Denver Health, who, let me tell you, they're not paid extra to do this work. And so this is how committed they are to the work. And so we truly thank you for sharing this wonderful work with us. Let's open it up. Oh, yes. One more round of applause. Open it up for questions. I'll get us started. You mentioned that a significant portion of your birthing population do not speak English. I was wondering what all of these checklists, interventions, engagement strategies look like for that non-English speaking group.
Sorry, stand back over here. So it's approximately 40% are non-English speaking, but the vast majority of those, I think it's, don't quote me on the exact, but somewhere between 80 and 90% of those patients are Spanish speaking. So we have everything translated into Spanish, including all of the resources. And a lot of our providers also speak Spanish. So that's one of the considerations of when we're trying to decide, okay, we have now at we have over 30 OB pair providers at Denver Health. So since there's so many different options, we can kind of prioritize a Spanish speaking provider if that's something the patient would desire. For the other less common languages, it's a lot of using translators.
Other questions? Oh, thanks, Kel.
Thank you for this awesome presentation. I'd love to hear more about the pre-training that went into rolling out the 5 Ps and having the frontline nursing staff interact with that moment with patients, and what sort of anticipatory guidance the nurses were given about possible implications of positive screening, how they would like kind of pre-script that conversation, or what kind of like snafus happened afterwards if some of that scaffolding hadn't been done, and how that went.
Yeah, so we actually use a lot of the CPC/QC's work. Why recreate the, what's the phrase? Wheel. Yeah, thank you. Why recreate the wheel when it already exists? So they have expert training that we had the vast majority of our nurses do. We didn't hit all of them, but that was a great first starting point. Again, we had all of our nurses do stigma and bias training, which then just kind of like set that assumption and kind of set that like bar of where we're at and where we can kind of approach things. I think the harder part of it, and certainly has not been perfect, is we have a lot of, I'd say, more control over the education and training that happens within the OBGYN clinics. But the family medicine clinics are the 12 other clinics that exist within Denver Health. And there's a lot of nurses and a lot of turnover as well. So what we've tried to do is create a OneDrive website that we use frequently at Denver Health that has all of the resources in one place. And then we've also created a one-page handout for the nurses that they can quickly like refer to it to hopefully kind of help to, because there was a lot of worry of, I don't know what to say, I don't know what to do. But I think a lot of that worry comes from when they don't know what the next step is. So we really focused on, okay, if this patient says that they have used, let's say, alcohol in the past month, then you say, thanks so much for telling us that. We have some options that can help you. And I think really having what that next step is going to be help to demystify it for the nurses. And our nurses are also incredible, and they're always asking to take on more and more roles and to take on more and more responsibility. So they were really excited when we asked them whether or not they would want to do this. Because we went back and forth for a long time. Do providers do it? Do nurses do it? But the nurses were the ones that were truly passionate about it and really wanted that continuing like medical education.
Other questions? So clearly I'm preaching to the choir here when I say that we got to better integrate, baby care with maternal care when it comes to this dyadic approach. But before we sort of launch that dyadic journey, I did notice that there was a very comprehensive birthing person focused plan, right? The prenatal period, postpartum, there was even a checklist. Now, there was no mention of, anticipatory guidance about the baby on the checklist because, we weren't there yet. But just curious to know how much of that checklist actually gets done in the postpartum period once the baby is born, right? So the point that I'm getting at is I think we all have good intentions about how to support that birthing parent, but the baby comes and their bandwidth, their priorities, how they want to spend their time is less about themselves and more about the infant. That's just sort of the universal theme, right? About parenthood and motherhood. And we certainly see it in the NICU. So just curious to know how that postpartum, all those kind of milestones actually happen.
Yeah. So and again, ideal state, not actual state. I think one of and I'm just going to keep building them up because I truly believe in their services so incredibly much, is Hard Beauty and the Peer Navigator services. All of the peers at Hard Beauty, not to steal their thunder, are also parents and understand what it is to be a parent and what it means to have a child and have either a current or a history of substance use disorder. So to help them kind of navigate those transitions, if I could highlight one thing that I care most about, it's probably that Hard Beauty referral on here. But again, we set them up with we try as much as possible to set them up with as many sources of support without being too overwhelming. And all of these are options, not required. But again, behavioral health, social work. And then we also have them meet with addiction medicine social workers while they're inpatient as well. And they, our addiction medicine social workers at Denver Health, have really taken, similar almost to the nurses, have really taken this incredibly, really, I don't know, inspiring attitude of how they want to be involved in these patients. And oftentimes the way it worked previously is that they weren't consulted, even though they had so many resources available to patients, so that we can always kind of remind that patient that we have things that are happening for the baby, but there's still things that are happening for you, and we still need to care about you, because if you aren't well, you're not going to be able to care for that baby. But yes, ideally, all of those things happen in the prenatal care. And if they don't, then we still offer them during the labor and delivery admission as well.
Other questions? All right. Thank you so much.